Hello, Namaste. Hi everyone. Today I'll be briefing. I have given the topic of briefing about diuretics and pedal edema, that is swelling of the limbs. See, most common causes of swelling of the limbs would be first is of course renal failure, second is heart failure, third is liver failure, fourth is hypoalbuminemia of any other cause like protein decrease in protein level in the body that can cause pedal edema. Or very rarely, hypothyroidism can cause pedal edema, which will be non-pitting type, that is hard pedal edema. So this pedal edema always it is worrisome because any common people who have pedal edema will be worried, saying that okay, something is happening with my body, so I have to take just check it up what is happening with my body. Some other causes, for example, once we rule out all the causes of edema, some rare causes like tablet induced or medication induced, for example, amlodipine, pioglitazone, all these things can cause pedal edema. So pedal edema definitely is a warning sign that there is something happening with our body, with our homeostasis, body homeostasis, something is happening. So we have to take care of that. We have to address it and we have to find the cause for edema. So coming to the most common causes, renal causes. Among the renal causes, see, most and foremost common what we see is in the diabetics or hypertensive, any cause which can cause any causes that will lead to kidney failure can cause pedal edema because of salt and fluid retention in the body. Because once the kidney fails, it cannot excrete salt and water from the body, so there will be salt and water retention in the body causing pedal edema. Second most common thing is cardiac failure, as we already discussed. So cardiac failure because of the poor ejection fraction, there might be retention of fluid in the body, so that can cause pedal edema. So third thing, liver failure. Because of the liver failure, there will be hypoalbuminemia, where the albumin will be less, protein will be less in the body because the protein production happens in the liver. In liver failure, so protein production will be less. So there will be third spacing, what we call the retention of the fluid all over the body, and hence pedal edema. Then other causes like hypothyroidism, what we tell, and a chronic pedal edema, where it will become hard, limbs become hard with the subcutaneous fluid collections. That can cause pedal edema. And rarely tablets, as I told you, can cause pedal edema due to salt retention. And sometimes, very rarely, any cause that can, any the reason, any cause, any etiology that causes, hypoalbuminemia can cause pedal edema. So, how do you recognize the pedal edema? There are few simple tests where you can check urine albumin to rule out any renal causes, creatinine to rule out any renal causes, then cardiac ejection fraction to 2D echo to rule out any ejection fraction problems or right heart failure to rule out as cardiac cause for pedal edema. Then liver, of course, we do liver function tests and ultrasonography just to rule out cirrhosis of liver or any liver pathology that is leading to pedal edema. Then, of course, hypoalbuminemia can be checked by through checking the liver function test. If all these things, and for thyroid, you can always check T3, T4, and TSH levels, thyroid values, which can tell that thyroid might be the cause of pedal edema. If all these things are excluded and we don't have any other cause, so we'll look at the medications what the patient is taking, and among the medications, we'll try to rule out which are the medications that can cause pedal edema or swelling of the feet. So once we come to the diagnosis of the pedal edema, treatment is very, very simple. Treat the cause basically, then treat what the patient is suffering. Treat per se pedal edema. Per se pedal edema can be treated with diuretics, what we tell urine producing medications. Those are called as diuretics. In diuretics, we have three major grades of types of diuretics. So one is loop diuretic, second is thiazide diuretic, third is potassium sparing diuretic. So loop diuretics are the most powerful diuretics that we have, which commonly comprises of furosemide and torsemide. And among the thiazide diuretics, we usually use this in systemic hypertension cases to reduce the salt level in the body. because they basically act on collective tubules in the DCTs, where salt will be pushed outside the body from the kidney. So hence, once salt is pushed, BP will be under control. When salt is pushed, water will also go with that. So there might be reduction in the blood pressure. So it is mainly used in control of hypertension. And it can also treat the pedal edema. Then last and weaker section of diuretic is the aldosterone, that is the potassium sparing diuretic. We also have eplerenone and all. Now Carendia is there, that is finerenone. So we have all these drugs. This potassium sparing diuretics, basically they control the potassium. They spare the potassium, and they make sure that the potassium is not excreted outside the body, which both loop diuretics as well as thiazide diuretics do. In thiazide diuretics, we have mainly what we can see day to day practice is hydrochlorothiazide and chlorthalidone. Chlorthalidone is a long acting drug. Hydrochlorothiazide is a short-acting drug. Torsemide is a long-acting loop diuretic, whereas furosemide is a short-acting loop diuretic. So, according to the patient's condition and needs, we treat them with the subsequent antidiuretics. So, if the patient is suffering from potassium, because both these loop and thiazide diuretics can cause hypokalemia, that is low potassium in the body, which can cause weakness, cramps, and sometimes paralysis of the limbs. So we have to concentrate on that. So to counteract that, we use potassium sparing diuretics. So these things are about the diuretics. What happens when the edema is still resistant with all the diuretics that you use? So how do you treat a resistant pedal edema? So most commonly we combine diuretic classes and to treat the resistant pedal edema. Even after giving 1 week, 2 weeks, 1 month prescription diuretics, if there is no reduction in the pedal edema, so always we use the combination of the 3 classes of diuretics. Okay, so that is one thing. Second thing is, even still it is refractory to the use of all these things, then we usually use continuous IV infusions of furosemide over 24 to 48 hours to reduce the diuretic resistance. And most of the patients respond to this. Diuretic resistance, when it happens, is when the patient is having hypoalbuminemia. When the albumin is less, please don't give high doses of diuretics. If you give high doses of diuretics, there will be it can lead to renal failure. So always be careful before using the diuretics. So even once you use the diuretic, what are the precautions that we should see? Once the patient comes with a pedal edema, just putting diuretics is not doesn't suffice anything. Always follow up the patient, saying that once your edema reduces, so kindly visit me so that we can reduce the doses of the diuretic. So always we should be careful in our in prescribing diuretics for the treatment of pedal edema. Hopefully, I have covered the basic things about pedal edema and how to treat pedal edema. Thank you, Sipla, for giving me the opportunity to speak on behalf of pedal edema, on behalf of the company. Thank you very much. Thank you all the viewers. If there are any questions, I can take it.